A very good day, my dear postgraduate students. The topic for the day is a SNIP, short note in pathology, pseudolymphoma. Lymphoma itself is a nightmare for us, and then what is a pseudolymphoma? Easier to talk than to write. Always the term is most important. It is defined as an uncommon benign disease characterized by lymphoreticular hyperplasia, and it can be confused either with a lymphoma or even a poorly differentiated carcinoma. This picture is a follicular non-Hodgkin's lymphoma. I would like you people to kindly appreciate the vague circular outline of these follicles. At the same time, I find that there is a kind of uniformity throughout the section. Please have these two things in mind. It is a follicular lymphoma. The threat today is not passivity, but pseudo-activity. The urge to be active, to participate, and to mask the nothingness of what goes on. Anyway, that is what we are doing day in and day out. The historical aspects. Kindly see these landmarks. Kaposi in 1891, and then Billerstein in 1923, Bafferstedt in 1943, and Lever 1967, Caro and Helwig 1969 have all coined various terms such as sarcoma cutis, lymphoma cutis, lymphadenosis benigna cutis, pseudolymphoma, and cutaneous lymphoid hyperplasia. And most of the cases have been cutaneous manifestations. Obviously, you find that the etiology could have been bite or scratches, injections, vaccines, Borrelia lymphocytoma, medicinal leeches, and drugs. Tattooing, surprisingly 26%. HIV is 2%. So this is a fairly decent detail that we shall reproduce. The classification can be based on the etiology itself, such as drug reaction, lymphocytic drug reaction, arthropod, and lymphadenosis cutis benigna, etc. Viral infections also have been implicated. Contact allergy and lymphomatoid contact allergy. Various terms have been used. We need not bother about it. Only thing, there is a plethora of terms, and let us see what else is there in store. This is a very important picture which I would like you people to kindly follow. A beautiful concept. So there is a B lymphocyte, and then there is a lymphoid follicle in which I am finding the small cleaved, then the large cleaved, small non-cleaved, and the large non-cleaved. And finally I get an immunoblast from which I can get the plasma cells or the small lymphocyte. This is the sequence of maturation. Now, what happens in any form of such malignancies is, the first thing I should remember will be a maturation arrest. It can be, say, at the level of a small cleaved lymphocyte. So what will happen is, there will be a proliferation of these, and I get what is called as a small cleaved lymphoma. If it has happened at this end, it will be a small non-cleaved lymphoma or a large non-cleaved. This is the fundamental. But obviously, you and I know that there have been more classifications than pathologists in lymphoma history. The reactive lymph node. Two things are important. I find that there is a pale region in the middle, and then there is a darker region. The pale region is because of the spacing of the cells, and I have got the nuclei with abundant cytoplasm. So they are the immature cells, the lymphoblast or the centroblast or centrocyte, etc. These are over here, and these are surrounded by a zone of mature lymphocytes, and I may or may not have the mantle zone in between the follicles. This is something I should remember. And this is a higher magnification of the same. Look at the small dark cells in the periphery, and then the larger cells pale relatively in the center. That is why I get a clear follicular pattern. But this is a normal lymph node that has undergone a reactive hyperplasia. So there are many synonyms I would like you people to go through. It can be nodular, it can be lymphadenosis, benign acutis, and here look at this case. Multiple nodules have been seen in the skin. It can be reactive nodules or sometimes it can be metastatic malignancy as well. This is from ResearchGate. I would like you people to kindly go through various etiological factors have been mentioned and accordingly what is the histological manifestation. So this is important. There is a pseudolymphomatous hyperplasia over here and I make a diagnosis of it. Finally, there has to be a clinical or a clinico-pathological correlation and a diagnosis is finally made. There are various causes with which it has to be correlated and probably the staging has to be done. The clinical presentation. Two things are important. It can be flat or it can be nodular. And when it is nodular, particularly in the forehead, one of the differential diagnoses clinically as well as microscopically can be a basal cell carcinoma. So it can be associated with chronic inflammation or infection, drugs, foreign bodies. Erosion is seen whenever it is in the skin, subcutaneous or subepithelial. Strangely, you find that mediastinal nodes can be involved, there can be a pleural effusion. All of this will be responding to steroids or antibiotics. And then again a plethora of terms, I am not going to repeat it, kindly go through it, they are quite interesting and can get you additional marks. This is important, SJS and 10. SJS is what is called as a Stevens-Johnson syndrome and 10 is again toxic epidermal necrolysis. These are the things. Sometimes there can be a combination of SJS and 10. In this, look at the pattern of the distribution of the lesion and probably an ulceration or necrosis of the overlying skin. So this is SJS and this is 10 and here there is a combination of SJS and 10. Courtesy EM note. And this tabular column again you people should memorize. It is between toxic epidermolysis, Stevens-Johnson syndrome and R.A.T.S, which means drug reaction with eosinophilia and systemic symptoms. So here whatever I have highlighted you people can follow. Eosinophilia can be seen and tubulointerstitial. Look, the kidney is also getting involved. And in this case, again an azotemia is being produced. There can be an epidermal necrosis. And look at this particular slide. I have pertinently mentioned it as variably confusing. So if this were to be the clinical presentation, look at this one, the differential diagnosis. I am more worried about this. There can be a gastric carcinoma which is mimicking a lymphoma. Sometimes I can get a maltoma also. There can be extranodal lymphomas. The cutaneous lesion is basal cell carcinoma. Dental lesions also are probable and a Sézary syndrome. So this is enough to confuse all of us. And an altered immunology also has to be considered, particularly in autoimmune disorders such as the Sjogren's. And drugs, as I had mentioned, anti-epileptic drugs, diphenylhydrantoin, phenobarbital, etc. Or something that has been used in infertility, the tamoxifen. R.A.T.S syndrome we already mentioned and multiple nodes we have already seen. This is interestingly Borrelia associated pseudolymphoma that is seen over here and kindly appreciate the well-defined lymphoid follicles with the pale immature cells and the dark mature cells in the periphery in the skin. Microscopically, what will happen is in a case of a pseudolymphoma, there will be lymphoid cells definitely, but there will be a mixture of plasma cells, neutrophils, macrophages, all. And a germinal center also can be seen. This, however, is not a lymph node. I am able to see some glands and it happens to be endocervical, in which case I am finding a lymphoma or a pseudolymphoma, which has to be confirmed or ruled out by means of the markers. So This again is a differential diagnosis. This gives a beautiful list of the disease. Kikuchi's or a syphilitic orchitis, IgG4, and indolent one. Indolent B cell can be a pseudolymphoma, eventually going in for a lymphoma. And these are all the various sites where they occur, and the histological markers. Kindly make a note of them and by heart. We have already seen this one. In this, it impinges onto the mucosa and it is above the mucous glands. And moreover, I am finding a dark cell over here and there is a variable distribution. Also, the starry sky pattern can be appreciated. This is a reactive follicle that we have seen. This is also a reactive follicle producing a pseudolymphoma, courtesy web path. So these are the features, kindly memorize. Now what happens is when there is a series of maturation, there will be the surface markers which are being produced and consequently there will be the antibodies against them which are used as immunohistochemical markers. That is why in a lymphoma we are getting a series of markers to diagnose exactly what type it is because the treatment will be varying. That of course is a different topic. It is to give you an idea of the plethora of cells that can be produced. So here again we have already seen and there are markers even for the reactive hyperplastic nodule. Compare and contrast. This picture I have already explained, whereas here there is a monomorphic uniform population and there is no lymphoid follicle. The cells obviously are large. It is a case of a large non-Hodgkin's lymphoma. So again, you find that a beautiful diagram of a follicle and then there is a mantle zone, the precursor cell and finally the mature cell and the battery of markers that can be named along with them. More markers and classification than pathologists. So the significances, it is found in the skin, found in various parenchymal organs, including lung and cervix. It can show a nodular hyperplasia also, and it is mixed with lymphocytes and the plasma cells. The differential diagnosis should be extranodal lymphoma. These are the other terms, and they should be based on IHC and molecular studies. And we have seen it regresses after immunosuppression or the steroids, removal of the offending agent. And it can be associated with anti-epileptic drugs or autoimmune disorders. This is what we had seen earlier. There is an attempted follicle, but here I am not able to see the immature and the mature cells, a clear case of a follicular lymphoma. Sometimes there can be a lymph node, a reactive follicle, and then an adjoining lymphoma. That we will be terming as lymphoma in evolution. So these are the modes of diagnosis and so compare it with this one. Obviously immature cells, dark mature cells, tingible body macrophages, starry sky pattern. So sometimes in the testis also we can be seeing them, and one such differential diagnosis for a pseudolymphoma will be syphilis, where there are more plasma cells, lymphocytes, and obliterative endarteritis. This is incidentally granuloma and syphilitic orchitis. When the only thing that matters votes in favor of nodes, the era of pseudo democracy begins. Thank you.